Hello, and welcome to the No Bad Questions podcast, where I try to learn in a conversational manner, to break down jargon, and to present the least amount of filtering as possible on a wide array of topics. I hope that you learn something too. If you do and want to support the podcast, you probably already know all the ways that you can do so. You can like, share, subscribe, hit the notifications, but ultimately, and what I hope you choose to do, is watch to the very end. With that, we'll start today's podcast. Hello, and welcome to this week's episode of the No Bad Questions podcast. My guest this week is Dr. Nikki King. Dr. King was born and raised in the coal fields of southeastern Kentucky. Before working in the healthcare industry, she worked for the Center of Business and Economic Research, studying models of sustainability in rural communities with a single economic engine. Dr. King has worked in the population health, clinical statistics, and health administration fields, developing high-quality, low-cost models of care for high-acuity individuals. She currently serves on the Indiana Rural Health Association's Board of Directors, the National Rural Health Association's Policy Congress and Government Affairs Committee, and as the board chair of the Rural Health Leadership Radio Board of Directors. Dr. King obtained her bachelor's degree in economics from the University of Kentucky, her master's degree in health services administration from Xavier University, Go Musketeers, and her doctorate in healthcare administration from the Medical University of South Carolina. Dr. King is also currently working to complete her psychiatric nurse practitioner degree and focusing on policy creation and development related to improving healthcare equity in the population health arena. Nikki, thank you for being here with me today. So, what is rural healthcare?
I gotta say, nobody's ever asked me that one. Let me think. I think when you say rural health, my knee-jerk reaction would be to say it's the health of people who live in communities that are, perhaps a little bit more isolated, a little bit smaller. There's a big part of me that wants to immediately respond and say that it's the health of people in rural communities. It's not that different than anybody else, because I feel like there's a lot of stigma about the types of health issues that people in rural communities face, and part of me wants to really emphasize that it's not so different than anywhere else, but that would be disingenuous, as there are very specific logistics issues when it comes to providing healthcare in a rural setting. So I would say that it is, when you talk about rural health, that is, the healthcare industry as well as the health of the individuals who live in smaller communities that are fairly far away from a population center, and that provides interesting logistical challenges in modern society. If you're asking for a specific definition, now that's an interesting conversation because nobody can really make up their mind on what specifically constitutes rural. In my mind, it's 50,000 or less in a community.
Well, so that's interesting because I appreciate the nuance of your answer, right? And the honesty that perhaps there is not a unified definition. And do you think that lack of definition contributes to the challenges in helping rural communities?
Oh, absolutely. I almost feel like there needs to be various tiers of rural. This has been an argument that I've had about the way that grant funding is distributed. When you look at, for example, this administration or that administration will say, we've spent X billion dollars on grants to provide this kind of care in rural communities. And when you look at who actually gets those dollars, a lot of times it's the bigger communities that may or may not meet everyone's definition of rural.
Mm-hmm.
Or, it goes to a bigger community so that they can partner in some capacity with something that looks a little bit more like what I envision when you say rural. I'm sure that's still worthy work, and I'm not trying to take away from it. But really, when I think about those programs, a lot of them exist for the purpose of helping to bridge significant logistical challenges that exist in rural communities that come about from not being able to take advantage of economies of scale and scope the same way that you can in urban communities. So I feel like, for example, when you talk about a tier one rural community, these are communities with 5,000 people or less that are more than 3 hours away from a city.
Mm,
And things like that. Again, when you talk about physician recruitment, nursing recruitment, and things like that, it's hard everywhere. Everyone's struggling.
right.
But, somebody who lives in Richmond, Virginia struggles is not going to look like somebody who lives in a small town in Alaska in terms of recruitment.
Right.
So,
No, absolutely. And I was actually going to ask about that. It's so a lot of your work, you're on some national boards and involved at a national level, but a lot of your professional work has been in the, lower Midwest in Appalachia. And do you feel like, from talking with your peers, from things you've researched, you've studied, that would need to be a major difference in how we handle rural in this region of the country, the Midwest, versus Alaska, versus the Dakotas, versus these places where a trip to the groceries 2-3 hours away?
absolutely. I think that those solutions are going to be very, very different, and the resources needed are going to be very, very different. I think that's a long discussion, but I'll give you an example. When you talk about the hospital that I used to work at, Margaret Mary in Batesville, is it hard to get people to work in Batesville, Indiana, in terms of like recruiting a psychiatrist or a specialist? Yes, but it's not impossible. They're an hour away from the city. That's enticing a physician to drive an hour out of their way to go work somewhere, usually accomplished by paying them a little bit above market rate. When you talk about recruiting somebody to go work at some small town in North Dakota that has 100 people and they're 6 hours away from civilization in every direction, that's not something a little extra something on the top for the physician is going to solve. So that's going to be a very different discussion on what that model of care would look like.
Right. Do you think, okay, so we can't get them perhaps to those remote areas easily, and particularly with COVID, everybody's talking remote health, telehealth, whatever you want to call it. Do you think that is going to play a major part of solving for this, a minor part, or do those people in those communities, from your experience, need literal, physical, hands-on care?
Man, I hate this question. Let me tell you why I hate this question. Because I feel like everybody wants to throw telehealth out as the silver bullet solution to literally every problem that rural communities have. And it's definitely a tool in the toolkit. And for some communities, it might be the whole tool, toolkit. Okay. But it can't be for everybody. Because I feel like there is something that you lose with telehealth. For example, I think of the power that a local rural doctor has within their community to control the healthcare outcomes of that community via relationships and personal investment in the community. And when you move to a telehealth only model, you're losing a lot of that. You're losing a lot of the ways that family practice or primary care physicians or, specialists, OB-GYN, et cetera, they leverage their personal relationship with their patients to improve health outcomes. And the physicians that I think of and the providers, nurse practitioners, physician assistants that I think of when I think of the people that I would want to emulate, that I really want to be like when I grow up, those are the people who are really, really skilled at leveraging those relationships. And I hate to see us lose that in rural communities. That said, is telehealth better than nothing? Absolutely. Do I want to see telehealth go away or even be scaled back after COVID, maybe someday goes away? No, I don't. I'm seeing significant challenges now from really aggressive telehealth offerings that were rolled out during COVID that allowed us to reach patients who previously were not able to be engaged for a lot of different reasons. In-person visits are just not practical for them. These are patients that before would have just frankly gone without healthcare in any capacity. And now with telehealth, we're able to get to them. Everybody would prefer it not to be telehealth. Everybody would prefer them to come in and have an in-person visit in order to build those relationships in the more old-fashioned way. But for some people, that's simply not going to be an option. So I think scaling back is going to create a lot more issues as well. So I realize that's not a very direct answer, but it's just very, very complicated. I guess if I had to sum it up, it needs to be a tool in the toolkit, but it can't be the whole solution.
That makes sense. And well, what I'm hearing in general about, okay, what is rural healthcare? How does telehealth contribute? And maybe this will flavor the rest of our conversation as well, is just that there's a ton of nuance to this, right? That no community perhaps is the same, or at least that there's some of them may be the same or similar enough that we could bring the same tools to bear, but that there's more nuance perhaps than current delivery structures, payment structures, policy structures are equipped to deal with. I mean, do you feel like I'm picking that up correctly in what you're kind of laying down?
No, I think that's absolutely the case. One of the big challenges I think that comes up from rural healthcare is it's very difficult to do it justice and distill it into an entertaining soundbite. And I think that causes folks to lose interest. But at the same time, I feel like a lot of the policy that have come out over the last, decade or so has been about trying to distill it as much as possible, which I understand the virtues of that. I really do. But it also, you lose a lot.
From my understanding, rural health has or had, still does its own challenges, right? And that's some of what we're talking about. But then you add in this opioid crisis from the last 10, 15, 20 years. And I know you've been deep in work supporting communities for that as well. So what does that look like? Because I think a lot of us in suburban or urban areas have a picture of the opioid crisis that may or may not match the picture of what that really looks like in the rural setting. What does that look like there?
I think that substance abuse in rural communities largely looks like it does in urban communities. I think that the biggest difference that you see is the proliferation of it and the lack of resources to address it. So when you talk about substance use disorders, I think one thing that's really important is to understand how heavily and strongly correlated it is with childhood trauma. Now, when you talk about things like adverse childhood event scores, you get a lot of reactions. Some people think that makes perfect sense, and you hear a lot of people who wants to tell you the story about this person that they knew sometime who had an absolutely charmed life, who went on to have substance abuse. And to that, I say bullcrap. You find me one person with a substance use disorder that didn't have an undiagnosed mental health condition before or undiagnosed childhood trauma, and I will just soon find you a unicorn. If it exists, I've never seen it, and I've been at this for a hot minute. I really fully believe that the issue when you talk about rural health is, for example, when you talk about the states in the United States, the lead for per capita child abuse cases, it's Kentucky and Indiana. When you look at those states being primarily rural states and the way that those cases exist in those rural communities, you have a lot of people who are growing up with childhood trauma. And when you look at things like mental health, when you look at the rates of people who regularly access primary care, and when you look at primary care physicians who are regularly screening for mental health, when you look at access to mental health providers as well as education on mental health, rural communities tend to lag far behind urban communities. And so when you talk about somebody who has a very general experience of growing up in a dysfunctional childhood home, from this, combined with their genetics, combined with cultural issues, they develop depression, anxiety. It goes untreated most of their life because most of the people they know have probably had a similar experience. They probably have similar issues. So it becomes a lot more of just work harder, just work out of it, just, bootstrap your way through it.
Right.
And you keep kicking the can down the line, and then before you know it, this has turned into a substance use disorder, and everyone is confused. And so I think that that's generally how it happens with rural. And then when you talk about what happens after that, so say this is a person who has now been diagnosed with a substance use disorder. They have been probably arrested, DUI, DWI, things like that. They've lost their license. they may or may not have access to Medicaid. As you look at a lot of the states who did not expand Medicaid access are states that are heavily rural.
Rural, yeah.
When you talk about, for example, women in rural communities and the type of work that they're doing, a lot of them are working multiple jobs at, say Wendy's, McDonald's, things like that. They're not really getting those salaried positions that comes with health benefits, and yet they don't have access to the expansion plans. And so then say you are one of these women. Now you've lost your license, you have no insurance, no treatment center is really going to take you. That's assuming that you have somebody who can even connect you to care in the first place, or you come from some kind of background that you even understand how to get help. And then from there, how are you going to get there? You don't have a car. Who's going to watch your kids? You probably don't have childcare.
Right.
And so all these things just compound. Whereas if you were a person who was living in an urban community, the chances that your primary care provider is going to appropriately screen you, that they are going to have a network that they connect you to in terms of resources. Maybe they're affiliated with an academic medical center that has a psychiatry department. They have these resources. The chances that you're going to be able to get to a treatment center is a bus stop away or a subway,
right.
And the resources that you probably have to help address things like childcare, much, much greater. Not perfect. Nowhere's got it good, but some places got a whole lot better than others.
Sure. No. Wow. Okay. So there's a ton in there. And
sorry.
No, it's good. So one of the things that struck me, though, early in your point there was about the rates of, I think you said child abuse in Indiana and Ohio lead the nation on like a per capita level or something like that. I've never heard that. Why do you think that is?
I suspect, well, I think it's a lot of different things. I think it was probably rooted in cultural corporal punishment. In terms of, I mean, who among us who grew up in Kentucky didn't get the joy of picking out your own switch from the tree? The belt, things like that. I mean, I feel like, and this is just colloquial, obviously, but like, I feel like or anecdotal, but when you talk about, people who grow up on farms, people who grow up in the mountains and things like that, and the type of discipline that, becomes commonplace. It's the way we've always done it, so to say, and everything.
Right.
So I think it's some of that. And then when you add that into a generation that ran into Oxycontin and, heroin and things like that, now you've got, the folks my age who grew up in households that were highly chaotic due to substance use disorders, with, a lot of like foster care placements and abuse and things like that from that, which adds a whole new extra dimension. So I suspect it's just a whole lot of that happening all at once. And poverty.
I wonder as well, and tied not just to that fact about the child abuse, but about so much of the other elements you mentioned in terms of resources and getting to appointments, getting from place to place. In your definition of rural earlier, you talked about, more isolated from infrastructure. So I just have to wonder if there's a level of social isolation that comes to play, perhaps, that also contributes to that with geographic isolation. I don't know. I didn't grow up in Southeast Kentucky. So, I mean,
yeah,
do you feel like that's a factor as well?
I think it can be. I think it depends. On one hand, the communities tend to be very tight knit. So when you have something egregious going on, it tends to be a lot harder to hide it. That said, when you're talking about, again, the sort of things that we know lead to emotional dysregulation in children now that are widespread cultural practices, I think it becomes even harder to break out of that, sort of mindset. Because everyone around you is reinforcing that mindset because they too grew up in that mindset. So, I think it's got benefits and challenges over urban. I think in ways it's easier to hide child abuse probably in urban settings because, again, you can hide behind anonymity in a way that doesn't, nobody's anonymous in a rural community. So, pros and cons.
Okay. And so backing up then, from that topic to the broader rural topic, and going back to, I think, to some of your early work around single economic engines. Let's break that phrase down and so what we're talking about is sort of company town type communities, right?
Yeah.
Where there's one major employer or one major financial driver who's employing maybe not everybody, but they're the ones providing the bulk of the good jobs and things like that. And particularly, I mean, that's the phrase, right? The Rust Belt, the coal towns, the things like this, that some of those companies are moving out. So do you see that rural health is harder, worse off, more challenges when that happens, when the company's gone? I would imagine so. Or does the town die? You know what I mean? And people move away.
I would argue the town dies when the hospital dies, but the hospital sure is hurting when the company dies. So, therein lies the opportunity. And actually, that's how I came to work in healthcare, was to study the gap between what happens when the company that runs the company town closes and the hospital closes. Because, when you talk about rebuilding a town after they've lost their big economic driver, to me, it's always possible. Hard, but possible. There are, especially now in this technology age, if you have the right infrastructure or can get somebody to sign off on you someday having the right infrastructure in terms of broadband access and things like that, technology brings some opportunity for rural communities to have things like call centers and things like that there that can help provide a lot of good paying jobs that can replace some manufacturing jobs without the additional logistical challenges of being isolated, like maybe in the mountains or something where you have all this extra travel that you have to accommodate for. The problem, though, is when the local healthcare provider closes, good luck recruiting anybody to come work in that town, because if there's no good hospital, nobody with young children is going to want to move to that town and work, even for an executive role or anything like that, because nobody wants to be an hour and a half away from the ER if they've got young children.
Right.
Or if they have aging parents, which we know now that the majority of adults are in that sandwich generation where they're both parenting minor children and taking care of their parents. If you don't have good access for, mom and dad to go to the ER, what about dad's heart problem and all this? And so you're just not going to take that job, and the town's going to die. So you're going to lose all your qualified people who could easily move to other places. So I think that when we talk about saving rural towns and saving small town America, I think absolutely front and center has to be the discussion about how to save rural hospitals. And right now, we're in a current environment where roughly 50% of rural hospitals are running at a negative margin and are, within a year or 2 years.
Pause on that. 50% of rural hospitals, I just want to make sure people that this sinks in. 50% of rural hospitals are operating on a negative margin, meaning they're losing money from taking care of people every year. And I mean, I know how they're surviving because I live in this universe, but can you break down for people how, okay, if you're losing money every year, how are you still here next year?
I think it depends. Some of them are getting by on hope and a prayer and a few windfalls, or borrowing money and hoping that something's going to turn around eventually. I think some of them had a nest egg from better days. Some of them are hoping that the payer mix might someday turn around, or borrowing for Peter to pay Paul. I think there's, all the desperation moves we all make, even in our own personal finance, when the bill doesn't add up.
Yeah, absolutely. Sorry to interrupt your train of thought.
No,
that's a stat, and I've heard that, but not everybody might be aware of just how much those rural hospitals are at risk today.
Yep.
And so COVID has driven a lot of people to rethink supply chains being overseas. Do you have any, this is a bit of a tangent from our core topic, but do you have any hope that as people rethink that and perhaps reshore, onshore, whatever buzzword you want to use, manufacturing back to the United States, that any of those companies are going to choose to build out rural areas and maybe help rejuvenate some of those towns?
I sure hope so, but they're not going to do it without significant local leadership. And many rural towns, frankly, keep electing the good old boys instead of the people who are actually going to do a good job of running the towns, and I think to their own detriment. I think that you would have to be very, very clever about tax incentives and understand that, for example, you might not be able to collect taxes from this company in the same way that you would have in a couple decades ago, but the benefits are going to be your town doesn't die. So, you would like to think people could have that kind of long-term vision, but I'm not sure long-term vision in politics is what any of us are witnessing in this period of my life. So I am hopeful there's opportunity there. Am I hopeful that people will seize on the opportunity? We'll see, because this would be a great opportunity to bring in local factories. But again, I think you have to look at the very specific challenges, particularly in manufacturing, that these organizations are going to face by going into an isolated rural community. For example, if you were to place one of these factories in my hometown in eastern Kentucky, you're going to have to contend with the fact that you have no interstate anywhere around you, and you have nothing but 55-mile-an-hour curvy mountain roads, and our gas prices are extremely high, which means you're going to have to ship all of the inputs and all the outputs in through these roads that are frankly impassable certain times of year because of flooding, impassable certain times of year because of inclement weather. Is it undoable? No, it's absolutely doable, but you're really going to have to make it worth their time. And again, that really comes down to local leadership and what they're willing to sacrifice.
Yeah. And we'll stay away from the political arm of that, but I'm sure there are some folks out there who are working hard to try to save their communities, and I'm sure there are others out there. There's a bell curve in every profession, right? There's probably some others out there that are just we'll be polite and we'll say complacent, perhaps, in what they're doing. So I think you're right. Some communities might be able to make it happen, others perhaps not. And I think some of that may depend on how much of this talk about reshoring actually happens. There's a lot of talk about it post-COVID, but how much of that is going to be real and sustainable long-term? Because it takes a lot of work and a lot of investment to move a factory from China, from the Philippines, from wherever back to here. So I agree with you. I hope that many of our communities and states that have seen that move out over the last 40 or 50 years see at least some of it move back in.
I think the biggest challenge that I see from these communities is people being realistic about what the future of their community is going to look like. I think there's a lot of denial on the way that things are going, a lot of denial about the aggressive trend towards urbanization. A lot of folks truly don't seem to believe that small town America is dying, or they think that pendulum is going to swing back the other direction. And I think as we look at the likelihood of resource constraints going into, frankly, in the next 100 years, which is probably going to be defined by climate trends, I think that that's unlikely. And you either adapt or you get left behind, and I think that it's coming to terms with that seems to be the death knell of many small towns. That doesn't mean that they don't have a role to play. I think it's just that they got to understand that this isn't something that's going to naturally swing back in their direction without any intervention.
Yeah. Well, why? Why do you think there's so much denial?
I think there's a lot of this is the way it's always been, and I do think that we have seen those trends. So, for example, I can only personally speak to Appalachia. You would have these periods where a new mine would open. They, hundreds of people would come into work at this mine from all over the place. You build a beautiful mining town around these coal mines, and then the mines lay off, and everyone scatters because there's just not enough jobs to absorb them everywhere else. And they would, frankly, move to Indiana a lot of times. They'd work in the factory for a year or two, and then another mine would open up, and everybody would come back. And so you've always had these peaks and valleys. And, in a lot of ways, it's been the same for a lot of rural communities. Or when I think of Batesville, I don't think anybody can imagine a world without Hillrom and Casket being located in Batesville. And I hope they never have to, but I think that's a conversation that they need to be having, just in case. Right.
No, that makes a lot of sense. And I think some element of that probably, if it's down to the way it's always been, then I think you're into sort of human nature.
Yep.
Right. It's I'm no psychologist, psychiatrist, but I think it's easier to say this is the way it's been for 20 years, 30 years, 100 years, whatever.
Yep.
It's logical. It'll stay this way.
Right.
As opposed to getting out the the section of your brain that does forecasting and forecasting a world that is dramatically different.
Right.
One of the other things, and I'm trying to get a demographer to talk to about changing demographics, because as our population ages in the United States, the true morbid fact is that aging population eventually will not be here, right? And I think that will make a lot of rural communities even more sparsely populated and even worse. And I see that around me, which isn't that rural. It's somewhat suburban here. There's some rural areas, but I drive through, a small village of 300 homes, and it's like, how many of these are folks of a elder age, whatever you want to call it, just older people, right? And how many of them will be here 20 years from now? And what do we do with that? What do we do with empty homes? That's a much broader topic than just rural health. Demographic changes. But do you think that the big picture 50,000 foot element I'm talking about of that aging population is going to make it worse, is going to make it better for rural health?
Oh, I think you're spot on. It's going to make it much worse. When you look at the population that currently live in rural communities, it's disproportionately aged and disproportionately sicker. So even for the younger folks who do stay, they're not going to live as long. Some communities have life expectancies that are in the 60s now. Wow. We're going to lose an entire generation much younger, and that's not even taking into account the generation that we've lost to, diseases of despair, suicide, overdose, et cetera, which is taking a huge hit. Because when you talk about someone who dies of an overdose in a rural community, the relative impact that has on the community is much, much higher when it's a small community. And, the earning potential overall, losing that one person's earning potential that would have been an adult that would have lived their entire life in that community is much higher than when you talk about a city. So I think that you're spot on with those challenges, and I think that it's going to continue to get worse. And I think that, that's one thing that I do hear a fair amount of talk about, which is people do seem to sort of intuitively understand this millennial generation and the Gen Zers and things like that are coming behind us are a little bit different, that we can expect some different trends from this generation than we have from previous generations. Mm-hmm. But, I think that's something that we talk about the way it's always been in rural communities too. Younger people go off to college, they meet their spouse, they work out there until they have kids, and then they move back home to mom and dad so that they have free childcare. And we're not seeing that with the millennial demographic. That population is not coming back. And I think it's going to take another 10 to 20 years before communities really, really feel the pain from that. And it really sinks in that a whole generation slipped out of rural America's fingers.
Right. I've read a lot about the suicide issue. Most of my reading's been around veteran suicide, but you're talking about suicide in the rural communities as well, and stacking that impact with death by overdose. And we'll caveat this by clearly saying this is one person's opinion, but do you feel like those are two sides of a coin, because they're both at the end result of a self-destructive element, right? You literally destroy yourself. You end your life when you commit suicide, and a substance abuse pattern is self-destructive. Do you feel like those are two sides of the same coin?
Oh, absolutely. Absolutely. If I've already mentioned, I personally don't believe in substance use disorder as a standalone diagnosis. I'm not saying it's never ever happened. I'm just saying I've never seen it. Right. I believe substance use disorder to be inherently in its core a coping mechanism to deal with a life that people has gotten to a point that people can no longer bear it under normal circumstances. This is a escape button or a numbing button. And I think when you talk about that, you have to talk about the various factors. So, for example, when you talk about substance abuse being a coping mechanism for a life that's become untenable, you have to talk about the poverty rates. If we're talking specifically to rural communities, poverty rates, abuse rates, again, the lack of mental health access and clinicians, the lack of safeguards from primary care that might have helped that person, either because they don't have insurance or because, they don't it takes 6 months to get in to see their primary care provider. No access to medication-assisted treatment. When you talk about all those things together and the way that they impact in terms of also no child care, no insurance, no transportation, and the way that they all can come together to make a person's life, frankly, unlivable. And, that makes heroin seem like a good alternative to living your everyday life. And when I have these conversations, invariably I always have somebody say, well, I did all that and I pulled myself up. Great. But, I also think that something's foul in the state of Denmark when we talk about, we're losing thousands and thousands of people each year to a struggle. Right. And it turns into a who's got it worse. Like we don't have a corner on misery. I think the point is that there's plenty of misery to go around, but maybe we could spend a lot of our effort on reducing the misery instead of adding to it, and that might actually move things in the right direction.
No, I love that. I love that. And yeah, let's not have the who's got it worse contest. Let's not have the who was the bigger overcoming adversity story is right. Not that we don't want to hear those stories, but let's hear them as we're working to fix things. And so let's pivot. We've been talking about the challenges. How do we make it better?
Right.
You're doing this. You're living it. You're working on it. How do we make it better?
Right. Yeah, I know that's definitely one of my biggest beefs when it comes to, some modern Appalachian self-proclaimed socialists, sociologists rather, modern Appalachian self-proclaimed sociologists. That's what I'm, there's a lot of talk of, I lived through this, I lived through that. Everybody should go to Yale. That's the solution. That's what you came up with from that. That's an interesting conclusion. Nobody should have to live through the things I lived through. The next generation should have it better than I've had it, which is what I feel like we really lost, is how do we make it better for the next one? Not how do we make sure that they endure the same things I did and that they do it the same way I did, So, I think that's my big argument is, if you have lived through hard things and you are a strong person, then that means it's your responsibility to pull up the next one behind you. God, the universe, the powers that be made you strong for a reason. It's your responsibility to lend your strength to the people who didn't get it.
I love that. And I think that taking the responsibility element is something that a lot of people are, I don't know, maybe I'm naive, but I feel like that's an attitude that's starting to pervade society. I mean, we've got a decade or more of really dramatic world events going on. And so I think that people are starting to see, okay, if I want to make it better, I have to do it myself, or at least contribute. You don't have to do it all yourself, but you have to contribute. So if you're a listener who's out there and maybe you don't live in a rural environment, maybe you haven't come face to face with an element of the opioid crisis, a substance abuse situation, how can those individuals for whom this conversation is a bit peripheral, how can they contribute?
First and foremost, and this sounds really tired at this point, but the stigma. I think the stigma is still pervasive, especially in healthcare professionals. And I think one thing that really changed my outlook on substance use disorders and mental health issues is understanding, for example, when you talk about things like theft with individuals with substance use disorder, when you talk about things like manipulation and lying, this one's a funny one because this is one that gets all the healthcare people real riled up. They can't stand it when their patients lie to them. And I think it's because it creates a lot of cognitive dissonance and it challenges everything I told you before, which is the power of that patient-provider connection. That is a symptom of the disease. It's such a keystone of the disease presentation of substance use disorder. It is one of the symptoms in which you identify somebody who has developed a substance use disorder, is that when they progress to the point that they are lying and manipulating to get their substance, that's how you know that it has officially entered that disease state. you can't personalize it, and you can't use that to justify stigma. We've all had those patients. We've all had them. You know what I mean? But you've got to understand that what you're seeing is a manifestation of the disease. It's frankly no different than, somebody who, the diabetes patients who comes in 100 times a day. They meet every appointment, they fill every A1C, they've done every diabetes education, and they still choose to go for the junk food. They still choose the Mountain
Right.
Dew, and then they get the amputation and things like that. And it's hard. I mean, that's the stuff that breaks your heart when you work in healthcare. If you're in it for the right reasons, that'll never be easier, but you've got to put the person who's struggling with substance abuse in that same category and realize that every day it's just a consistent effort to help them make a better choice. But ultimately, you're not going to be able to make it for them, and you can't personalize their outcome beyond knowing that you did what you can do to be kind to them and treat them like a person, because nobody is going to believe in themselves enough to want to get better. Nobody is going to love themselves enough to want to get better if everyone in their life is treating them like they are subhuman. That's definitely the one thing that's not helping.
So fighting the stigma. That's rule number one for everybody, doctors, nurses, non-healthcare people, is trying to fight that stigma around this. And in fact, in a way, what you've said is we need to look at that, particularly if you're a caregiver.
Yep.
You need to almost look at that as like a gift that they've given to you because they've told you the severity of their situation.
Yep. Yeah, that's how, I think that's how you know that when they are doing things to you, and that doesn't mean it hurts any less that they stole grandma's jewelry and sold it, but understand that is not them. That is not if you're a parent who's had that situation, that is not the person you raised. That is not an indictment on your morals or what you told your kid. That is a disease process. You're witnessing somebody who is not in control of their behavior.
Mm-hmm. So you've had this pretty successful career thus far on more of the administrative side, and you're choosing now to go into the clinical side and get a nurse practitioner, training. And what has made you choose to do? I mean, that's a lot of work. What made you choose to do that?
Frankly, when I think about the parts of my job that make me really excited, I love designing new treatment programs that really kind of meet people where they are and make the most of limited resources. Frankly, when you're doing that, a lot of this is making it up as you go and flying by the seat of your pants and finding clinicians that are willing to go along with Nikki's harebrained, half-cooked ideas and, go into these places and do these things is not always the easiest thing in the world. So I thought, maybe if I have the ability to do it myself and prove that it can be done, then I can build the model and then they will come, as long as, it's a lot easier to sell somebody on a model you made up if you've been doing it at least for a year and it's your license on the line too. Right.
No, that's awesome. I love that. Okay. And so that not a lot of people would do that. Not a lot of people are going to invest their whole career in, trying to solve for this huge, nuanced, as we've said, interwoven, complicated problem that is rural health. And you've chosen to do that. Where do you get your drive, your energy, your passion? Obviously, I mean, you're wearing that on your sleeve. You came from that environment, trying to help that environment. But where do you get the drive? Because the energy to do that, a lot of people, it's going to wane over the years. And I've known you long enough to know that I don't think it's waned. In fact, it's potentially growing. So where are you pulling these reserves of energy?
I drink a lot of coffee, like a lot. The only place up from here is IV. So IV coffee. So yeah, I believe very strongly that these are problems that can be fixed. And frankly, what keeps me up at night is the insanity that we keep beating around the same problems just because those same old demons. We're not willing to get outside the box. We're not willing to listen to people who don't look like us. We're not willing to validate the experience of people who have not lived the exact same life that we've lived. we have lost something in that innovation round. You know, when I think of the things that I grew up really loving about America, you know, innovation would be the top three. You know, one of the things that I always knew that in the United States that we did as Americans better than anybody else is innovate and solve problems and use every tool in the toolkit. And I am seeing that go away, and it drives me batty. And I see it go away to the detriment of our communities, and I see what could be in terms of how can we leverage the resources that we have and stop talking about the things that we don't have. That's a waste of time. Stop talking about the way we wish people were. Also a waste of time. And let's deal with the people that we have, the resources that we have, and think of a new way to use them. You know, it's almost like, you know, you think of the good old days, you know, our ancestors living up in the mountains and things like that. They could take anything and make anything out of it. And they could fix something and they could make it work. And that, you know, that Ringer washing machine that lasted 200 years will last 200 more. You know, people had a way of doing that. But again, that comes from a certain level of emotional investment in our communities that I want to see come back. And again, I think that you kind of have to prove that it can be done, that we can be that America little Nikki thought we were again. Or maybe for the first time, depending on what your personal experience is. You know, I think you got to believe, and you've got to have that level of faith. And like I said, frankly, every minute is excruciating. So I'm just working towards that future that I know could be.
Well, I think that's awesome. So understand the nuance, take responsibility, have empathy, see not just what is, but what could be. And I think, you know, building relationships within the communities are, you know, the 5 through lines of what we've talked about today.
Yep.
Did I miss anything that you think is critical to improving the health of rural populations in America? Or you think those 5 at the big picture level are really what each of us could do to contribute?
I think you pretty much hit it on the head.
Well, I think that those are all doable. I think several of them are hard.
Yes.
But what matters is they're doable. And so I think that is, you know, a good message for people who might listen all the way to the end here and catch this. So I appreciate you coming on and talking to me about this issue that you're so passionate about and is incredibly meaningful for I don't think it's just our rural populations, because it's intertwined. The rise or fall of rural populations is going to have an impact on suburban and urban populations as well. So it's just such an important topic for people to get their head around and understand, and if they can, to contribute. So, Nikki, I really appreciate it, and we'll leave it at that. So
thank you.
Thank you very much.
I appreciate you. Thank you.